Okay, hi, good evening, everyone. So, I think today we are going to discuss as the exams are approaching. So, we'll be discussing about some of the common DNB questions that have been asked in the exams or the potential questions that can be asked in the exam. The idea of doing this is to cover almost the whole breadth of foot and ankle, more common, topics in foot and ankle, and some real things as well. So let's start with the first question. So the question one is about a picture in which a foot is being showed and a test is being performed. So the question is identify the test being performed, describe in detail how it is done and how is it helpful clinically, and name one clinical condition in which it will be positive. So I mean the test that is shown is basically that the foot is actually resting on a block or we say a wooden block. And what is evident is that the first metatarsal is actually held free, while the lateral aspect of the foot as well as heel is actually on the wooden block. So basically, it is what it is allowing is it is allowing the first metatarsal to drop down below the wooden block, and hence it is allowing it to plantar flex. So this test is actually called as Coleman block test. So Coleman block test, what do? We basically put a wooden block uh, on the heel and on the outer aspect of the foot, leaving the first metatarsal free to drop so that the first ray can plantar flex and it allows the forefoot to pronate. Why are we doing this? Uh, because in a case of cavo varus foot, what happens is that the forefoot pronation leads to a hindfoot varus because as soon as the patient's foot touches the ground, the first thing to touch the ground is the first metatarsal, and then just to maintain the tripod, heel has to touch, and then the fifth ray touches, and as a result, heel drifts into varus. So this heel varus is basically driven by forefoot deformity, or it is called as forefoot driven hindfoot varus. And we have to differentiate whether the varus is driven by forefoot or is it a fixed hindfoot varus deformity. So if during this test the heel goes into valgus, like in this case, you can see that the heel is actually into the valgus. So that means the hindfoot varus is secondary to a forefoot deformity, and it is flexible and it does not require any surgical correction. So how is it helpful clinically? It helps in identifying whether an osteotomy of the calcaneum is needed or not. If Coleman block test is positive and the hindfoot connects to valgus, that means it's only the first metatarsal osteotomy which is needing along with some tendon procedure, but we avoid doing the calcaneum osteotomy. And name one clinical condition in which it will be positive. It is Charcot-Marie Tooth disease in the early stages. So coming to the answer key, the Coleman block test, as you can see, without the block, the heel is actually into varus. And as soon as you put the block, and the first metatarsal is dropping, so heel drifts into valgus, which means the subtalar joint is mobile, and the varus is hindfoot varus is driven by forefoot cavus. So place 1 inch block under the heel and lateral forefoot, leaving first metatarsal free to plantar flex. A flexible hindfoot varus or a forefoot driven hindfoot varus will correct to neutral or valgus position. It eliminates the contribution of plantar flex first ray and forefoot pronation to the hindfoot deformity. How does it help? It guides the surgical treatment because flexible hindfoot varus would get corrected with forefoot procedure, while a rigid varus needs hindfoot corrective osteotomy as well. And the condition in which it will be positive will be Charcot-Marie Tooth disease. The second question is about an operative setup, and it asks what is this setup used for, what are the common portals, what are the indication, and what nerves can get damaged during this procedure. So as you can see, this is basically a non-invasive ankle distractor system uh, which is being applied to the ankle. It is helpful in distraction. we use this procedure, we use this for anterior ankle arthroscopy. So this is an anterior ankle arthroscopy procedure. What are the common portals? The two portals which are being commonly used are anteromedial and anterolateral portal. What are the indications? Well, there is plethora of indications for ankle arthroscopy, anterior ankle arthroscopy, arthroscopic debridement, osteochondral lesions, ankle impingements, lateral ligament repairs, arthroscopic ankle arthrodesis, kylectomy, synovial biopsy or synovectomy, or anything. And what nerves can get damaged during the procedure? During the anteromedial portal, it is the saphenous nerve, and during the anterolateral portal, it is the superficial peroneal nerve. So coming up to the answer keys. So this is the anterior ankle arthroscopy using a non-invasive distraction. Anteromedial portal is just medial to the tibialis anterior, and anterolateral is lateral to the peroneus tertius. Indications we already discussed: anterior ankle impingement, OCDs, ankle instability, loose body removal, synovitis, arthroscopic arthrodesis. Anteromedial portal, if you look at this, just across over here, you have the great saphenous vein as well as the saphenous nerve. So that is something which can get damaged. Even a tibialis anterior can also get damaged. But I think most significant is in the anterolateral portal, where you have the superficial peroneal nerve branches which are coming very close to it, and they can easily get damaged, especially the intermediate one, which is supplying the fourth and the fifth rays. There is another anterocentral portal which is right across in the center, but not many people use it, or it is almost abundant because it has a high risk of causing damage to the neurovascular bundle or anterior neurovascular bundle. So third question, a 34-year-old person with an injury from fall from height. So patient presenting with the recent pain and difficulty in walking. What is the diagnosis? What are the components of deformity? How do you classify this condition, and what will be the management? So if you can see in this patient, there's an X-ray which is shown, which shows that the calcaneum is a little bit abnormal. Uh, if we look at it, the height is slightly reduced, the length has been shortened. On the axial view, there is a varus and a widening of the heel. So basically, it is a malunited calcaneal fracture, and there is also evidence of subtalar arthritis. So I already enumerated all the components of the deformity. There would be reduction in the heel height, widening of the heel width. There can be something called as a lateral exostosis over here, which will cause peroneal tendon impingement. Uh, the heel would drift into varus, and the length would be shortened. We can also go further talking about the radiological parameters, and then we can talk about things like Giesen's angle and Bowler's angle as well. How do you classify this condition? There are different ways, but what we use most of the times is the Stephens and Sanders classification. And what will be the management? It actually depends upon what are the symptoms as well, and the anatomical diagnosis. So like in this case, it would be eventually a subtalar arthrodesis along with the exostectomy. So malunited calcaneum fracture with subtalar arthritis. Heel components of the deformity is heel varus, shortened length, decreased height, and lateral exostosis. Stephens and Sandberg classification. Type 1 just has a lateral exostosis which causes peroneal tendon impingement. Type 2 would have subtalar arthritis, and type 3 would have an associated malalignment. Most of the time, it would be hindfoot varus. Treatment is a subtalar arthrodesis. In cases of, there's another thing in which uh, you have reduced ankle dorsiflexion also in severe cases when the heel height is getting compromised due to a change in the talar declination. And if that happens, then a patient would require not just a subtalar arthrodesis, it would be a distraction bone block subtalar arthrodesis. In this case, the heel height is relatively preserved, not so bad, And if you look at the talar declination, that has not really changed. So this probably would just be a subtalar arthrodesis. Question number 4. So 55-year-old lady presented with pain in bilateral big toe. Question is, identify the deformity, enumerate the methods to measure it, what are the risk factors for this deformity, and what is the treatment. So first of all, identification of deformity, it is easy question. It is a bilateral hallux valgus deformity. Methods to measure it is basically radiological measure. So there are certain angles that we draw. Uh, there is the hallux valgus angle, intermetatarsal angle, distal metatarsal articular angle, as well as hallux valgus interphalangeus angle. Risk factor for the deformity, we'll talk about it. There are modifiable and non-modifiable risk factors. Modifiable risk factors, the only modifiable one is wearing shoes with narrow toe box, and non-modifiable, most of the time it is genetically, and there are other factors like inflammatory arthritis, uh, including rheumatoid arthritis, any neuromuscular disorders, etc., and presence of flat foot. What is the treatment? If the patient has minimal symptoms, just icing, bunion pads, a customized inserts, calf stretching. But if it is surgical, it in all likelihood it is going to be a bunionectomy with an osteotomy, as well as a lateral soft tissue release and medial soft tissue plication. So the deformity is hallux valgus deformity. When we're talking about the angle, so first one is a hallux valgus angle, which is an angle between the first metatarsal and the first phalanx or the proximal phalanx. Normal angle is around less than 15 degrees. The second angle is between the first metatarsal and second metatarsal, which is IMA or intermetatarsal angle. Normally it is less than 9 or 10 degree. Another one is hallux valgus interphalangeus, which is between the proximal phalanx and the distal phalanx, and it is less than 10 degrees. And the fourth one is a distal metatarsal articular angle, which basically is an angle between a line which is perpendicular to the long axis of the metatarsal and a long axis and along the articular surface of the distal aspect of the first metatarsal head. So this angle is normally less than 10 degree, but if the distal metatarsal angle is increased, and that means the articular surface is deviated laterally, what it becomes is it becomes a congruent hallux valgus, in which there is a hallux valgus, but the joint congruity is maintained. And whenever we are correcting it, we need to take note of that, that if there's a distal metatarsal articular angle, then we have to add, apart from the shifting, we have to add something like a closing wedge, or we have to rotate the metatarsal accordingly to correct the DMAA as well. So intrinsic factors, genetic factors includes ligamentous laxity, pes planus, rheumatoid arthritis, gout, and second toe deformity or a second toe amputation or something like even a brachymetatarsia. Extrinsic factors is high heel and narrow toe box shoes. Treatment, non-operative is modification of the shoe, bunion pads, toe spacer, and exercises. And surgical is a bunionectomy, lateral soft tissue release with corrective osteotomy of first metatarsal plus minus an Aiken osteotomy, which is of the proximal phalanx.